So just an introduction, my name is Manjul Chatterjee. I'm in New York City. I'm the section chief of abdominal imaging at Cornell. I'm also the vice chair of quality for our practice, and I'm an abdominal imaging enthusiast. So I was here in your seats less than 20 years ago, but more than 15 years ago, as an OMI fellow myself. So I was here as a resident, and I have to say, this was one of those experiences where you meet folks outside of your bubble. And you get to talk about different ways of imaging and different ways of doing things. You see different perspectives. And that ability to connect and learn different ways of thinking about things is so critical. Because you can read things 100 times and you can have your same friend or colleague explain something to you 100 times, but it doesn't quite hit the mark as meeting somebody from a totally different locale, from a totally different perspective that introduces a topic to you. So I'm really happy to be here, and I want to thank the organizers and David for inviting me as well. If you haven't figured out, I'm very low-key and casual. So if anyone has a question or if you find something interesting, just raise your hand. Or even better, just say Manjul, and we can talk about it. The goal is to be interactive, and I'm looking to make a connection with you all, such that you leave here kind of feeling that same way. All right, to help facilitate that, there are no printed slides for this. A, because this presentation was made on the fly somewhat recently, completed this morning. And B, I want you all not to be flipping through papers. And I want you to just pay attention to me and the slides. And I will give you this presentation on a thumb drive, so you can look at it later. The engagement that I do want you to have is with your phone or your PC. So if you log into the Wi-Fi, I'm sure you all do, and please go to this website now, polev.com. / my full name 619. I'll give everyone a couple seconds to go there, and then we'll get started. If you don't have a smartphone, there is an option for. That's perfect. Yeah, there is an option for. This is my ambient lighting preference. There is an option for texting. I should have put a QR code on this one, obviously. And then just do me a favor and stop playing with your phone when you're done, or when you've connected there, so I know that you all have found it. Pretty good? Almost there? Anyone else need more time? Okay, wonderful. So let's get started. What is your mood about this topic on focal liver lesions? I want to gauge the room and get a sense of where you all are at. Are you excited, number A? Are you B, kind of frazzled? Or I'm trying to figure out that other emoji is sad. Are you C, angry? Does this topic bring you feelings of getting the diagnosis wrong and frustration? Or D, are you crying about this topic? Meaning, does this come up over and over again and it just brings you sadness because you don't come to a conclusion? I'm happy to hear that, see that most of you are excited and happy about this topic, but I know it does bring a lot of consternation and stress. And so just so I can focus this topic based on what you all need, could you just indicate here which lesions here give you the most stress? Like which of these topics that I can cover today will answer and kind of supplement what you all need already? And I'll give a couple seconds so everyone can kind of weigh in on this. HCC, hard diagnosis, especially in a non-cirrhotic. Cholangiocarcinoma is a great mimicker, so I'm with you. I would have chosen B as well. C is hepatic adenoma, which I think is a chameleon. It can take on a lot of different forms. FNH seems less like a concern here, and then hemangiomas. I'm glad to see that some people did mark that because hemangioma also seems simple, but it's really not. Okay, so let's give you guys something to think about. Just in the back of your heads as we're going through this presentation, I want you to be thinking about the way you practice radiology in general. I was talking to Saren earlier today, and in America, the way we practice radiology is very disconnected from the patient. We're not meeting the patient, we're not talking to them, but we have the electronic medical record. And I would urge all of you to get to know your patient before you read the scan, because their history, their demographic, their age, the priors, where they've come from and how they present to you is critically important in determining which liver lesions you're going to diagnose or not. You want to be thinking about what contrast agent is on board when you do the MRI or the CT, sort of giving yourself a roadmap for which sequences you're going to look at and how. And I'm going to try to give you some, some tips and tricks on how to do that. Even protocoling cases, if you're reviewing the day's cases and one of these diagnoses comes up, how do you choose a contrast agent? How do you determine which protocol to use? And how do you determine how to image that patient? And finally, what are some pitfalls for different contrast agents? So I think, generally speaking, when looking at hypervascular liver lesions, overall, arterially enhancing lesions in the non-cirrhotic patient, 90% of them are benign, okay? So if a patient does not have liver cirrhosis, 90% of those lesions are going to be benign, and the liver is tricky like that. Just trying to shift gears from MSK into the liver is like a little bit tricky, but when you're thinking about each organ, in your head, you have to have a mental mind map, right? Of how often are these things malignant, how often are they benign, and how do I work through that? In the case of the liver, you really got to know the patient. So you got to be thinking of their age. Are they less than 45? I'm 44 this year, so I'm still in that category, and my liver lesions are benign, I hope. You want to be thinking about their liver enzyme tests. Are they elevated? Are they normal? Is the liver reacting to this mass? So you might be reading something that looks really aggressive, but the clinician, the referring doctor, you tell them about this and they're like, what? The patient's normal, the LFTs are normal, there's no biliary obstruction, like what are you talking about? So you've got to be in sync with what's going on. How many lesions are there and what's the patient's history? These are critically important to sort of start the conversation, if you will. So in terms of contrast agent selection, we have a whole talk on this, which is lovely. I think it's on Thursday, so I'm really excited to talk about that. But just giving you a general idea, the topics you want to be thinking about is, do you want to use an extracellular agent or do you want to use a hepatobiliary agent? And the difference there is going to be huge in terms of what the appearance is on imaging. Extracellular agents, they move into the space as early as 90 seconds, and a hepatocyte-specific agent, where 50% of it is being bioprocessed by the liver, moves into the hepatocytes as early as 90 seconds and then distributes into the extracellular space. And so if you look at this graph, depending on which agent you're using, you've got to be really thinking about the enhancement of the liver in respect to the tumor, right? And so if the liver is enhancing like this, a hypervascular tumor will be enhancing more, right? But what if the liver happens to be enhancing at that same level? Then that tumor, even though it's hypervascular, might look iso, right, to the remaining liver. So you've really got to be thinking about where you're at. And so for the liver, I just want to spend 5 seconds on, just the background of how to look at an MRI and determine what phase you're in, such that you know how to evaluate a liver lesion. So looking at these different phases, the early phase, early arterial and late arterial, these are going to be the most important phases for most liver lesions. And you'll notice the early arterial, there's no enhancement in the liver at all. Too early, right? Nothing going on in there. Just the aorta's bright, which is lovely, but the liver itself, you can't make any discrimination on terms of lesions. This late arterial phase where the aorta is very bright, but you also see a slight bit of portovenous enhancement, that's the money shot, right? So when you're looking at an MRI, you see the aorta bright as heck. That looks like an MRA, right? Like an arterial phase study that you'd be examining. Well, that's not quite normal. You want to see a little bit of portovenous phase enhancement, and that is the perfect way to say whether or not there's arterial enhancement or not of a liver lesion. Very quickly thereafter, within 70 seconds, you'll hit the portovenous phase where there's confluent enhancement of the portal vein and the liver looks brighter. But then within seconds of that, you hit the transitional phase, and that's more of an equilibrium phase. There's a red line here because all of these phases are helpful for diagnosis of liver lesions. But once you get to this transitional phase, and then for a hepatobiliary phase like EOVIS, the hepatobiliary phase itself, you can't make any diagnoses of washout or pseudocapsule or any of these terms that we use to diagnose liver lesions. So again, remember this red line, stop at the portovenous phase, do not make diagnoses based on the transitional phase. Who here uses EOVIS or any hepatocyte-specific agent in your practices? Okay, so the numbers are limited, so more. So I'm seeing about like a third or a half. And how many of you use those agents routinely versus having to say, give this patient EOVIS? How many patients are routinely using EOVIS? Okay, so this is kind of a little bit maybe. Okay, perfect. Yeah, Primovis. Yeah. So you'll find that depending on the practice patterns, different people use different agents. I will tell you that in the next 10 years, the proliferation of MRI and hepatocyte imaging is going to reach across the world, and we'll see more and more of this. So this topic is right on. So when you're thinking about contrast agents in MRI of the liver and looking at a liver lesion, what you want to be thinking about is what contrast agent you use. So this is a hepatocyte agent, and this is a hepatocyte agent. Both are Eovist and multi-hands. The Eovist is highly processed by the liver, right? So in your head, be thinking that if an agent is being bioprocessed not only by the kidneys and excreting into the urine, but also being picked up by the liver and metabolized by the liver, then that agent is not going to stick around the bloodstream very long, is it, right? Because it's being pulled out of the bloodstream actively into the liver and into the kidneys. Whereas an extracellular agent or even a mixed agent that doesn't have as much hepatocyte uptake will stay around in the bloodstream for up to 3 hours. In that case, the imaging of a liver lesion then will align with that of the blood pool, if that makes sense. So the blood pool, as long as the contrast stays in the aorta, the longer it stays, the imaging characteristics will be very different as well. So here's an example of that. Looking at a typical hemangioma, T2 bright, pre-contrast, not much going on. Arterial phase enhances probably peripherally. Portal venous phase, still enhancement. And then by the delayed, you still see contrast within the lesion, right? And that is because there is a plentitude of multi-hands in the bloodstream for minutes to hours after the exam. In the case of Eovist, not really the same, right? This is the exact same lesion with Eovist. And you'll notice T2 bright, great. But then on the arterial phase, there's not as much contrast there, right? Or immediately, the body is starting to pick up that Eovist. And so you don't see that beautiful flash-filling appearance. And then by the portovenous and the hepatocyte phases, the contrast is totally gone. So you want to be thinking about which contrast agent you give and how much of it is in the blood pool based on the phase of the imaging you're looking at. Here's the same patient with a different lesion. So this is the lesion that has arterial puddling on the periphery on arterial phase imaging. On portovenous phase imaging, we see some filling, and at delayed, it's completely enhanced. That's great for hemangioma. For Eovist, here's another lesion, T2 bright, same kind of idea as this one. No enhancement, and then as you see on delayed imaging, there's no enhancement essentially. This is a cyst. So be thinking about the phase that you're looking at and what the enhancement looks like. So hemangioma, we're going to go by quickly. It's the most common hepatic lesion. The prevalence is here, females much more than males. And these are vascular channels. They're hyperintense on T2. They match the CSF, and also they follow the blood pool. So be looking at the aorta, be looking at the vascular structures to see if the hemangioma kind of follows that. A hemangioma with Eovist will be dark. So when you look at the delayed phases on hepatocyte imaging, you'll notice that as soon as you hit the transitional phase and then into the hepatocyte phase, there is no contrast within the lesion. But on the earlier phases, you see puddling peripherally and then some centripetal filling. Remember, no hepatocytes within a hemangioma, so the Eovist does not retain any of the contrast on that imaging. Here's another case with Eovist, and this is for a suspected hemangioma. You'll notice here at the second phase, the arterial does not look very good. I'm curious if anyone knows what's going on here with the arterial phase of the Eovist. A lot of motion there, and we see this a lot with hepatocyte images, but specifically Eovist or Primavist. And this is a diagnosis called transient tachypnea of Eovist. So you inject this contrast agent into patients, and it causes the patients to start having tachypnea. And so that's unfortunate because that's the exact phase we need to diagnose a hemangioma or so many arterially enhancing lesions. So this is a major pitfall I want you all to keep in mind of this contrast agent, and it's independent of the patient's natural status, disease state. It's just a side effect of the contrast agent itself. So some pitfalls of Eovist and hemangioma that I want to talk about. The transient tachypnea is one. It can obscure the characteristics of the puddling. We talked about that because the hepatocellular uptake begins really early. And high-flow hemangiomas, like the one I showed you earlier that looked flash-filling, can be mistaken for hypervascular Mets. So when you look back at this case, where'd it go? When you look back at this case, you can imagine how on this early phase, it's easy to call something like this a hypervascular metastasis, right? But then when you look at further phases, it kind of fills in, so then you're reassured with the T2 appearance that this is probably a hemangioma. But it is a concern, you want to keep it in the back of your head. Is this a hemangioma that's flash-filling, or is this something that's actually an arterially enhancing metastasis to the liver? And we'll get into that in a second. Hemangiomas can be hypointense to the normal liver as soon as 3 minutes later. That can look like washout, so you want to be kind of careful that you don't overcall a hemangioma as washing out when it's actually just following the blood pool. So in all, when you're thinking about a hemangioma, if you get that diagnosis on the protocoling list, I wouldn't use a hepatocyte agent for that. Use an extracellular agent, because remember, hemangiomas are vascular lesions, so you want to use a contrast agent that will best stay in the extracellular space in the vascular pool, such that you can evaluate them really well. All right, here's a case I want to show y'all. So there is a liver lesion here, and you all can take a look at this one. What do you guys think of the capsule here? What's going on with this capsule right outside of it? Does it look smooth or retracted, right? So this is a case of a T2 mildly bright lesion on the T2 fat sat. You see it there. There is capsular retraction, no fat in the lesion, and then kind of progressive enhancement. Call out what you think this might be. Give me some ideas, differentials. Cholangiocarcinoma. Any other calls on this one? Sorry? Amazing. So maybe this is a sclerosed breast metastasis. Maybe it's been radiated, and therefore there's capsular retraction. I called this a cholangiocarcinoma, and I felt pretty good about that. I think I added this to my teaching file, so sure of it. Then I got a prior MRI in the mail. I don't know if this all happens to you, but patients read the report, and then they're like, oh, actually, I've had 7 MRIs at an outside institution. Let me send them all to you. And so I got imaging from 5 years ago, and this is what the lesion looked like 5 years ago with the capsular retraction. But you'll notice, like, when we compare these, what's happened to the lesion? It's shrunk. All right, so is that a cholangiocarcinoma without treatment? No way, right? Impossible. So what could this be? Aha, could it be a sclerosed hemangioma, right? And so that's a whole other topic. Sclerosed hemangiomas are basically hemangiomas where there is a more fibrous component, and there's been thrombosis of some of those central sinusoids. And when that happens, the T2 hypointensity goes away, first of all, but then also you don't get that classic filling or that puddling along the periphery. So in this case, the priors are going to be essential. So I recommended a biopsy on that case. Then I got the priors. The patient was scheduled for biopsy, and then I had to put my foot in my mouth, add an addendum, call everyone back, and say, oh, I think this might be a sclerosed hemangioma. Anyways, they did the biopsy anyways because they didn't have confidence in what I was talking about, and it turned out to be hemangioma, which is great. So keep it in mind as another prop. I'm going to show you a zillion examples in this presentation such that every single time you just develop a pattern of what this might look like. Here's another example. On the arterial phase, you get the sense that this thing is peripherally discontinuously enhancing, right? Like most of us, I think, might think this is a hemangioma. Am I right about that? Like, not totally sure because this is a single phase CT and I don't have any filling. Again, 21 months later, another CT was done, and this is what the lesion looked like. So it's gotten smaller, but also you'll notice it lost its peripheral discontinuous enhancement and it developed rim type enhancement. So if you have just this lesion, if you have just this imaging, then you'd call this a cholangiocarcinoma. If you have the prior, this automatically becomes a benign hemangioma. So it is critical that you know how many MRIs the patients had in the past and what that showed, because it can save your butt. I was going to say a different word, but it's really important. So always be sure to really scrutinize the patient jacket. Ask the patient, have you had prior imaging? At our institution, we give them a questionnaire, and it says, how many MRIs have you had in your life? And they write like 7 or 8, and then in my packs I see 1. So then I know there's like a disconnect there, and there's got to be more out there. And then in a perfect world, then I reach out to the doctor's office and I ask them and try to get more. But in an imperfect world, the patient gives me the images later, and then I make an addendum. Here's another example of a great lesion. On the CT, you can see there's continuous enhancement. T2 doesn't look right. This is not good for hemangioma again. And then the enhancement, peripheral enhancement that is continuous, and then on the delay, this thing fills, okay? So this was also called a cholangiocarcinoma, and that was a sclerosed hemangioma, so keep it in mind. Here's another case, the T1 pre-contrast imaging, no contrast on board, you barely see the lesion. On the arterial phase imaging, on the arterial phase imaging, you see that there's hypervascularity within the lesion. On the later phases, you barely see the lesion, and on none of the other sequences do you see it. No diffusion. And then the most important thing is on the hepatocyte-specific imaging, you don't see a lesion there. Call out what this is. Who knows? What do you think? How would you read this thing? This is a tricky one, right? Like, you don't see much. This is the only finding on the entire MRI is this, this lesion that's on the arterial phase. What's that? Maybe a flash-filling hemangioma. Not a bad idea. You should see it on the T2 then, right? It should be bright on the T2, hopefully. This is only on this sequence. A what? FNH, maybe. That's a good one. That's a stealth lesion. We're going to get into that in a second. That's a great thought. And on hepatocyte imaging, they can be ISO because they take up the contrast. That's a great thought. This is only seen on this lesion. This is called a THID or a THAD, or transient hepatic intensity attenuation difference. Are people familiar with this diagnosis? It's a perfusional defect, essentially. And this is my nightmare. Is it real or is it not real? Can we recommend a biopsy? Are you going to be able to see this thing, or is this just a perfusional abnormality that's going to go away? And one good way to find that out is to look at the priors and see if it's stable. Another good way to do that is to look at the hepatocyte imaging and see is there a defect in the lesion itself. And this is a sign of underlying liver disorder, but honestly, many, many, many people have these. They're very common. And it has to do with differential enhancement based on blood flow from the hepatic artery to the portal vein. All right. Next lesion, everyone's favorite topic, FNH. So FNH, or focal nodular hyperplasia, is a hamartoma of the liver, right? So when you think about hamartomas of the abdomen, in the kidney, right, we have oncocytomas. In the liver, we have FNH. So it's normal hepatic tissue that's overgrown, right? And so it's the most common, it's most commonly found in premenopausal women, although 10% critical in men. 40% have this central scar, so keep that in mind. You see an arterially enhancing lesion, and then the center of it, there's no enhancement. So that's called the scar. You wanna, if you see something like that, hang on to it. They're stealth on other phases. Very hard to see. Why? Why are they stealth? Why is a FNH stealth on other sequences? You don't see it very often. Anyone know? Exactly. This is a hamartoma, normal hepatic tissue. It's going to have similar imaging characteristics to everything around it. So keep that in mind. FNH do have this transporter called OATP, and so they retain the hepatocyte-specific contrast when administered. They're benign lesions. You don't need any follow-up, but they get misdiagnosed all the time. And the scar itself does not take up the E of its contrast. So I'll show you a bunch of cases of that now. So here's a typical appearance of FNH. You can see here there's a focal lesion. It's encapsulated. It does look like there's a scar centrally. That scar is seen here. It's T2 bright. No fat in the lesion when you look at it. And then as it enhances arterially quite a bit, and then on more delayed phases, it becomes ISO to the rest of the liver almost. You can't really see it well. What happens to the scar on the delayed imaging? It enhances, right? And the reason that it enhances is it's fibrous. So you have a fibrous scar, and it takes time for the contrast to fill inside that scar. And so therefore, these scars have T2 hyperintensity because of the fibrous component, and they enhance delayed. The most important thing is going to be this one. What sequence is this? What sequence is this that I'm looking at here? Who knows? Equilibrium? Maybe. What's this finding here in the middle? Aha! So that's excretion of contrast into the bile duct, right? So you know this is the hepatobiliary phase because there's excretion into the bile duct, and the liver is diffusely uptake, right? It has diffuse uptake of the contrast agent. What about the mass? Well, it has complete uptake, so you know this is an FNH. So again, FNH, arterially enhancing, T2 bright scar, enhances delayed, and at hepatocyte imaging should retain the contrast. Here's another example of an H. This one does not have a scar. And similar to the participant who just said these are stealth lesions and they're very hard to see, this is the ultimate stealth lesion. Where is the lesion? Does anyone see a lesion here? Raise your hand if you see a lesion. In segment 3 or 4, okay. So maybe like folks are talking about this thing? No? No? Where? No? Aha! Can you see it? It's hard to see, right? Like we blow by these lesions because they're very hard to see, except for the arterial phase. But on the CT, you can see it beautifully right next to the IVC. Interestingly enough, on this CT, they called this, I think they thought this was the IVC because they didn't call anything. So in your head, when you're scrolling, our head does funny things without telling us. And so you're scrolling through the images and you're like, oh, that's the IVC. But no, the IVC is right next to it. So this was an FNH. And on later phases, you can barely see it. But on a hepatocyte imaging, you can see it retains the contrast. So that's very helpful. Really helpful. It can save the day, because it can avoid a biopsy in a patient just straight from the MRI. Here's another example of an FNH. This one does have a beautiful scar. No fat within the lesion, T2 bright. Arterially enhancing, the whole thing becomes inconspicuous on delayed imaging, and the scar starts to take up contrast. And then on hepatocyte type imaging, you see there's this type of retention. Everybody look at this image and kind of memorize this appearance, right? This is so pathognomonic for an FNH. If you see it, you got to call it. Don't wibble wobble on this type of appearance. The scar, does it take up Eovis? Does it retain the Eovis or no? No. Why? It doesn't have an AOTP transporter. The scar itself is fibrous. The rest of the tissue is a hamartoma, if that makes sense. Here's another example of an FNH. This one has a beautiful scar, very obvious, and this is with Gatavist. So you've got this hyper-enhancing lesion, scar enhances delayed, and it's T2 bright. Do you need Eovist for this case, or can you call this an FNH done? What do people think? Who thinks this is diagnostic of FNH? Raise your hand if you'd call this FNH done. Or who thinks you'd say, maybe a hepatocyte-specific MRI should be performed? Yeah, okay, so I think you can go either way. There's no right answer. There is no right answer to that question. For every single liver lesion, if we then recommend an Eovis study, we double the amount of exams that are done, you know? So you really want to be thinking in the back of your head, which of these, with which contrast agent can I make a confident diagnosis? Here's another case. This is a 25-year-old female. First thing you want to be thinking in a patient when you see the liver, is the liver cirrhotic, right? Like what's the pretest probability of this thing being malignant? Is the liver cirrhotic? That's got to be the number one question. In this case, no. So we have a lesion here. It's encapsulated. There is a scar, right? But on the delayed imaging, what's going on with this? Does it enhance? No, it sure doesn't, right? And on the T2 weighted imaging, is the scar T2 bright or dark? Ugh, so that's not great. Who's got an idea of what this diagnosis could be? Fibrolamellar HCC. So now we're thinking, we have a 25-year-old, a young female patient, non-cirrhotic liver with a liver lesion that does not quite fit an FNH. What do you do here? Do you recommend an Eovis-specific or hepatocyte-specific exam, or do you biopsy this thing? Biopsy, maybe Primovis, like tough call, right? The answers are not always obvious. In this case, we went straight to biopsy because there is nothing of a liver lesion this big that is not going to have to go to biopsy. And more importantly, in your head, again, be thinking about the patient. This liver lesion is painful, no? I mean, it takes up like half the liver, and it's causing compression on the capsule. So this lesion absolutely has to come out. So there will need to be a tissue diagnosis, you know? And I would like to get that tissue diagnosis before they take it out. So this lesion was biopsied, and this came back a fibrolamellar HCC, which is rare in young females without cirrhosis. So keep that, again, in your head. Be thinking, young female, no cirrhosis, AFP is normal, big tumors. These are diagnosed late, and the scar is hypointense. Remember that. I'm sorry. Scar is hypointense, not hyperintense like an FNH. And the reason for that is it calcifies. So on MRI, calcium is dark on all the sequences, and so the scar will always be dark. If you did a CT, you'd see a lot of stippled calcification within that scar. And 80% of them have heterogeneous arterial enhancement as well. Here's another example of an FNH, of a fibrolamellar. We have a very large lesion. The scar is dark on all the sequences. But what's going on here on the portovenous phase? What do you think? Arterially enhancing for sure. And then what's going on here? Is it iso like an FNH? Does it blend imperceptibly? What do y'all think? What's going on here? Is it iso to the liver adjacent, or is it darker? Darker. So how do we call that? Washout. So this is an HCC. All right. So this is like some of the tools that I use to diagnose FNH versus HCC versus fibrolamellar. Here's a nice case. This one's beautiful. This is a 42-year-old female. There is a liver lesion, very hard to see on the T2s. On the SSFSE, the T2 is bright. What's going on here? This is in phase and out of phase. What's going on here? We have out of phase right next to in phase. Here's the lesion. Has fat in it. Okay, what kind of fat? Bulk fat or intravoxal fat? Intravoxal fat. Why? What's it missing to be bulk fat? Yeah, exactly. What's the typical imaging finding of bulk fat or macroscopic fat? It's too bright, yeah. What else? What about the in and out of phase imaging? What kind of artifact? There is loss of signal here. Aha, exactly. So you're looking for loss of signal or chemical shift or India ink artifact for that case. So in this case, there's other sequences that are given here, and you can see the lesion again, right? Here it is. And then on delayed phase imaging, you can see it's dark. So this is washing out, right? So this is the sequences that we have here. This turned out to be an adenoma. So we have an arterially enhancing lesion. It has bulk, it has fat in it, and then it washes out on delayed imaging. So this is an adenoma. Here's another example. So we have how many lesions? One or multiple in this liver? Multiple. So when you see multiple liver lesions, you're thinking in your head first, metastasis. Is this metastasis? Okay, great. You guys are on it, which is great. So we look at the in and out of phase imaging. I'm just trying to see how this projects. We look at the in and out of phase imaging, and what's happening with some of these lesions? What's happening? Is there dropout? In one of them there's dropout, yes. Not in all of them, though. And then on delayed imaging, we have arterial enhancement, and then what happens on the portovenous phase here? What's happening to these lesions? They wash out. So what's your differential for this case? And is the liver cirrhotic? Is the liver cirrhotic? Let's answer that question first. Non-cirrhotic liver, okay. So you got a non-cirrhotic liver, multiple arterial enhancing lesions, one of them has fat in it, and then they all wash out. Sorry, what? Speak up, what? Multiple adenomas, yes, or adenomatosis. Good thought. Other differentials, keep them coming. What? Speak up, don't be afraid. Maybe hemangioma. All right, what do you think the T2, though, here? A little bit heterogeneous for hemangiomas, right? Like a hemangio should be homogeneously bright on the T2 unless it's sclerosed, you know? So we got adenomyomatosis. Could this be multifocal HCC? Could be. You said could be. Why did you say could be? I'm curious. It's non-cirrhotic, though. Which population of non-cirrhotics get HCC? We have fibrolamellar, right, in young females. What other population does not develop cirrhosis, but they still get HCC? Hepatitis what? B. Okay, so in the history, you got to know the history of the patient. Does this patient have hepatitis B? Yes or no? If yes, these are HCC. If no, what's the prevalence of HCC in a non-cirrhotic liver? Terrible. You're going to be wrong 99 out of 100 times. So keep in mind, like, what's the patient's population? What's the AFP? Is the liver cirrhotic? How old is the patient? And that's going to help you. These are adenomas, and they're inflammatory adenomas. Wonderful. Anyone know what this sign is called for an adenoma? This T2 bright halo. Atoll sign. Wonderful. You guys are up on focal liver lesions. I love this. So an atoll sign is the compression of the normal liver sinusoids around an adenoma. It causes this halo or ring sign. I have no idea how that relates to an island. An atoll is like a sandy barrier around an island, I guess, that separates it from the ocean. And so that's where they came up with this name. And so you're looking for that sign possibly to help you with adenomas. Adenomas are the chameleon, okay? So if you all think of, like, in your head, what are the diagnoses that cause me stress? I'll tell you mine. TB, syphilis, myeloma. What other atypical things? Yell them out. What other things cause you guys stress? Add to your list adenoma, because they can look a lot of different ways, and they are benign. But they overlap, right? With FNH we've talked about, young women we've talked about, and arterial enhancement with FNH, but also with HCC, because they enhance and wash out, and they can contain fat, they can hemorrhage, and they can rupture, all of which HCC can do too. So be thinking about hepatic adenoma in the back of your head. These are tumors that are estrogen or androgen dependent, and they are related to the dose and the duration of estrogens. In a lot of young females that are on oral contraceptives, you will find these tumors. So again, flipping through the chart, if you see that the patient's on oral contraceptives, then they have multiple liver lesions, they're non-cirrhotic, could this be adenomas related to OCPs? And it increases to 30 to 40 million in long-term users of OCPs. So it is a lot, and they're very prevalent. Small are generally asymptomatic, but as they get larger, they cause discomfort in about 40% of cases, and they can bleed like hell. So any of these arterially enhancing lesions, be mindful of that, especially the very vascular lesions. If they grow too big and they rupture or the capsule gets disrupted, they will bleed. And you might see that on imaging. And rarely they can undergo malignant transformation to an HCC. So what about that malignant degeneration? Let's say you know you have an adenoma and you're getting a follow-up and you're like, is this malignant now? Like, how do I know that? It's grown, but adenomas can grow too. So in the back of your head, be thinking of features that are suspicious for HCC, like interval growth of a mass, elevated serum AFP, and then any of these risk factors. So an adenoma in a male, common or uncommon? Very uncommon. So if you see rapid growth of an adenoma in a male, maybe that's an HCC or malignant degeneration. Any of these conditions, glycogen storage disease, anabolic steroid abuse, beta-catenin, which is associated with those two things, or larger than 5 centimeters or multiple lesions are risk factors for malignancy. This is important. I think this is important. So how do you subtype an inflammatory adenoma? So you're at like 99%. You found this to be an adenoma. The patient's on OCPs. And you're like, I want to go to 170% on this diagnosis and subtype the adenoma. Who does this in their MRI report now? Tries to subtype the adenoma in the report itself. Anyone? Okay, amazing. So this is one thing you could take home from this lecture, right? Add a little bit of extra value to the clinicians because your GI docs and your liver hepatologists, they know these types of adenomas. So you should too, because if you put it in the report, you'll sound so smart and you will come back, those hepatologists will definitely come back to you 7 times over because they'll think you're so sophisticated, which you are. So inflammatory type adenomas, forget all this. Just remember they bleed like crazy and they're associated with OCPs and fatty liver. Inflammatory adenomas, they bleed, okay? Steatotic, if there's fat in it, fatty adenomas, those are HNF1 alpha. HNF1 alpha, that's the name of it. And those are very low risk of hemorrhage and malignancy. So fat in an adenoma is reassuring, very reassuring. And then the beta-catenin is the nasty one. Again, adenoma in a male doesn't quite compute. I'm thinking like estrogens for adenomas. But if you see a male with an adenoma, or they have glycogen storage disease, or they're on anabolic steroids, those wash out and they have the highest risk of malignancy compared with any other adenoma. So I'm going to show you a bunch of cases like that. To give you an idea of the prevalence or the frequency, the most common types of adenomas are inflammatory and HNF1 alpha. Remember, inflammatory, what's the sign we're looking at for inflammatory adenoma? Hemorrhage. Okay, let's go on. HNF1 alpha, what's the sign you're looking for? Fat, exactly. And they're benign, almost always benign, HNF1 alpha. Beta-catenin, males, and they're much more risk of malignancy. So here's an example of an inflammatory adenoma. This one is beautiful. What's going on over here on the outside of the liver? Huh? Subcapsular hematoma, excellent. So this one's ruptured, right? This one has ruptured and there's blood along the liver. Right away in your head, be thinking of which tumors rupture, which ones cause blood, and adenoma's right up there. And then here we have an atoll sign on the T2. So this was an inflammatory adenoma. Here's the next type of adenoma. We have a lesion here that you can see really well. It does wash out. And then on the in and out of phase imaging, on in phase it's bright, on out of phase imaging it's dark. So this has complete fat in it. The fat is a great sign. So steatotic adenomas are HNF1 alpha. They're associated with oral contraceptives and adenomatosis, very low risk of hemorrhage and malignancy. So if you see a hemorrhaging adenoma, don't call it an HNF1 alpha. If you see fat within it, then you can call it. And then when the hepatologist comes, you let them know that these are typically benign and you feel pretty good about it. Why don't you get a 6-month follow-up and then another year after that? Beta-catenin is in males. By all means, if you see an adenoma in a male, please add that to your impression. Beta-catenin positive adenoma, these are at high risk for malignant degeneration. Short-term follow-up is recommended because they really are. Here's a T1 weighted image, T1 pre-contrast weighted image. How do I know that? It's fat saturated, the pancreas is really bright, the CSF is dark, right? And then I look at this case and I'm like, is there contrast on board? No. So what's going on with all this hyperintensity within the tumor then? Hemorrhage, right? So this one is bleeding like crazy and it's a male. Ugh, don't feel good about this one. And this one was resected and in fact it was a collision tumor of an adenoma plus HCC. So some half of this had started to bleed. So here's a quick way to think about it, and I know I'm beating this to a dead horse, but I also feel it's where you can add a lot of extra value as a radiologist. And at any conference you're at or whatever, be thinking about the ways you can insert added value into your report, right? Because then when your referring clinicians read that report, they're like, oh wow, this person knows what they're talking about, but also they're talking in my language. You know, they get what I'm thinking. When the hepatologist sees that you call something an adenoma, the very next question they're going to ask is what type? The next question they're going to ask is, should it be biopsied, resected, or watched? So you got to be thinking about that, and one way to do that is to be thinking of which subtype it is. So again, first question, fat or no fat? Fat, all right, that's an HNF1 alpha adenoma. Does that need to be resected? Is that going to be malignant? Probably not, so you're going to do a short-term follow-up, great. Adenoma, no fat. Is it bleeding? Yes, then it may be an inflammatory adenoma. No bleeding. Is it a male? Does it wash out? That's beta-catenin. Those transform like crazy. You got to resect that thing. Here's another case. Let's take a look at this one. I got to look here. Where's the mass? So is it washing out or not? Arterially enhancing, does it wash out? So what's our differential here? Is the liver cirrhotic? No? So what's our differential? Do people think this could be an adenoma? What do you guys think? This was diagnosed in HCC, right? Arterially enhances, it washes out. This was diagnosed HCC, which I didn't totally understand, because in this case, you can see here that there's no cirrhosis, so the pretest probability is pretty low for this to be an HCC to begin with. And then it does sort of blend imperceptibly here, but then it washes out. So there can be atypical variants of FNH that also wash out. So keep that in mind, that just because it washes out does not mean it's an adenoma or a adenoma or HCC. And in fact, FNH can absolutely have fat. And classically, FNH plus fat should not reduce your diagnostic confidence. Get an EOVIS study at that point, right? That's a great time to get an EOVIS study or a hepatocyte imaging study, because then you'll see retention within the lesion. So EOVIS can definitely help differentiate between FNH and hepatic adenoma. Forget all the text here. Let's just look at the EOVIS appearance. Look at this EOVIS appearance and this one. Does this retain the contrast? Here's hepatocyte-specific imaging. You see the bile duct enhancing. Does this retain? Not as well, right? There is a little bit. It's kind of stippled. And then again, like really burn this into your head. The appearance of an FNH at hepatocyte imaging should look just like this. Confluent retention, and then the central part will not have any of retention. The hepatic adenoma can be sort of stippled when it does have retention, but it doesn't look like an FNH. Any questions about this? This is important. Okay, here's another atypical FNH with microscopic fat, and this is with EOVIS. So what do y'all think? So here's a lesion again. It looks like there's possibly a scar here. There is some fat within it, so people were like, is this an FNH? The hepatocyte looked really good for that, and so this was an atypical FNH at the end of the day. All right, here's another case. Where's the liver lesion? I put an arrow on it. I'm going to give you guys a couple seconds. I just want to point out there's one liver lesion here, and then there's another liver lesion here. What's going on with this liver lesion? And what do you think this is pointing to? What organ normally lives here? Well, here's the adrenal gland. Someone just said, oh, okay. Who said that? I love that. Who just said that? Because that's my brain when I'm reading. I'm like, oh, okay. Sorry?
Maybe the bottom one is RCC that is metastatic to the liver.
Love it. So maybe this patient had a nephrectomy, right? This is a little bit high for that, so there's another organ that typically lives up here. But that's a great thought. So like you see a missing kidney and then you see a liver lesion, maybe that's an RCC met. That makes sense. Why did they have the kidney out? I'm going to find out, and then that's going to guide the way I call this. This one, no. This one had another organ up here that's missing. Spleen. What's the diagnosis? Aha, splenosis. Splenosis. So be thinking, when you see a liver lesion, it's not always related to the liver. And this is actually an extracapsular splenic deposit, and there's another one. So the multiplicity helps you, and the fact that the spleen looks kind of messed up helps you. This patient had trauma and had splenic rupture, and there was spleen that just like flew all over their upper abdomen, and many of those little nodules will grow up into mini spleens. They're cute when you know it's splenule. They're not so cute when you're trying to work it out. Anybody here seen an intrapancreatic splenule? Okay, that's another nightmare you don't want to deal with. When you're looking at these, if you have the spleen as a reference or some remnant of the spleen, compare the contrast enhancement and see if they're similar or not. Splenosis is usually due to trauma or splenectomy. It's seeding of splenic tissues into the liver. They're typically subcapsular. They have really serpiginous arterial enhancement, sort of that heterogeneous early enhancement that the spleen does. And you can get a fibrous capsule with a rim around it. Okay, next case. Let's look at this one. What's going on with this contrast enhanced study? What's up with this liver lesion? What's inside there, do y'all think? Fat, right? Look, it looks funny. Very, 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 very dark. So you want to put an ROI on that. And as soon as you put an ROI on that, you'll see it measures on CT. What would this measure? Minus. Yeah, fine, minus. Exactly, minus. So you know there's fat in there. If you saw this lesion in the adrenal gland, what might you call it? Angiomyolipoma? Myelolipoma. So how do I remember that? For me, I'm like, okay, the word adrenal already has an A in it. So it's not going to be adrenal angiomyolipoma. No. 2 A's, that doesn't work. Adrenal myelolipoma. And then the kidney has the angiomyolipoma or the AML. So for the in the liver, you can also get these. They have bulk fat, this huge amount of fat within it. They are benign. They have more bulk fat compared to extra-adrenal, and it can really vary. It is associated with tuberous sclerosis, just like in the kidneys, and the fatty component is going to be what you're looking at. What's the differential for this? What causes fat in the liver like that within a lesion? Could be a lipoma, but they're not very common. What about a liposarcoma metastasis? That's a good one, right? Bulk fat from a liposarcoma somewhere in the abdomen. Could be a teratoma, though they're not very common. And then remember, if there's a dominant vascular component, maybe this is a hypervascular hepatic lesion. HCCs, they have minimal fat, not like this, not a huge amount of fat. So be thinking AML if you see a lot of fat, and the liver is the second most common site. Here's another case. Let's take a look at this one. No cirrhosis, no risk factors for chronic disease, and we have the imaging that's given here. Multiple lesions, right? A lot of them. Peripheral enhancement, that's really continuous. No fat in the lesions. What do y'all think of this guy? And there's multiple, right? There's 1, 2, kind of similar to what we were talking about before. What do you think this could be? Well, it could be that these are metastases in this case. So keep that in the back of your head. When you see multiple lesions, back to our original conversation that we had, is could these be Mets? Now, when you're thinking about hypervascular metastasis in the liver, you got to have a good differential. The way I remember this, and I would suggest some of you kind of think of this, is the mnemonic MRCT, like an MRI/CT. What's M in MRCT for hypervascularity? Melanoma. What's R? RCC. Okay, MR, done. Slash, now we're talking about CT. What's the C? Choriocarcinoma, wonderful. And T? Thyroid. Okay, so that's your easy mnemonic for hypervascular metastases in the liver. MRCT. And then you want to be looking for the primary. So then start scrutinizing the thyroid, the kidneys. You want to be looking if the patient has a history of melanoma. Maybe the patient's missing a kidney on the imaging, and you're thinking, oh, maybe that is metastases. So hypervascular metastases are the most common malignant lesions in the liver. They're 18 to 40 times more common than primary malignancies of the liver. Remember, again, if a patient is non-cirrhotic, don't start calling HCC, even though it's tempting, because it's so rare in the non-cirrhotic liver. Unless the patient has a history of hepatitis B, you will be almost always wrong. So even though it's beautiful on the pictures, it just doesn't match the diagnosis unless there's a real history of liver disease. Multiple routes of spread to the liver. 10% of metastases are solitary, 70% involve both lobes, and they commonly exhibit a continuous room of enhancement on the outside, so something to think about. This is a nice chart. I like this one, just to give you an idea of like what you're looking at. And again, hypervascular liver mets are pretty easy, this whole MRCT thing. Carcinoids, keep in mind. And then again, high signal intensity on T1 weighted imaging is due to internal hemorrhage, or it could be melanin. So keep that in mind. Here's another example, multiple enhancing lesions within the liver. They're all arterial enhancing. And then what did I find here? Yeah, so someone just said it. Carcinoid. So this is neuroendocrine tumor. So when you see something in the liver, then start looking for the primary. And if you find something in the mesentery, that's a neuroendocrine tumor. Here's the sad part. Patient had a prior tumor, a prior MRI. We didn't see much. But on the diffusion-weighted imaging, there was a lot there, but we missed it. Why did we miss it? Because we just looked at the post-contrast and we didn't scrutinize the diffusion-weighted imaging. So when you look at these tumors for neuroendocrine mets, look at the diffusion very carefully. Cholangiocarcinoma is the second most common primary hepatic tumor. Males much more than female. There's 3 types you can see here. And there's risk factors, PSC being one of the biggest ones. When you look at mass-forming cholangiocarcinoma, you'll see that there's peripheral rim-type enhancement that's confluent, and then it fills. These look more nasty. They're associated with capsular retraction. Hypervascular ones have a better prognosis than other types. Be thinking about the patient's chart and look at the CA19-9 level. It may be elevated. HCC in the non-cirrhotic is the final category. This is a patient that has hepatitis B. Just always be thinking, does this patient have a hepatitis history that might give them HCC? They can be very clinically silent, especially in the early stages. This is the final case. This patient had a nasty liver lesion here with multiple septations and daughter areas. There's also finding in the leg, which made no sense to us. Aha, hydatid cyst or echinococcus. Wonderful. So be thinking of other things. All right, we have 2 more minutes. Just pay attention for 2 more minutes and we're done. This is a 38-year-old female who presents with a history of indeterminate liver mass found at ultrasound. Here's the liver mass. What do you want to do next? I don't know if this is updating. Shout it out instead. This poll everywhere is kind of janky. What do you guys think? Who thinks it's an MRI without contrast? Raise your hand. Who thinks it's a single-phase CT with contrast? Okay. Who thinks it's an MRI using hepatobiliary phase contrast agent? Excellent. And a PET CT, too much, right? And the right answer here is MRI MRI with multi-phase. Which of the following tumors in the liver is hypervascular? Okay, excellent. Proper answer here is HCC. That's excellent. 94% of you are saying that that's true. Pancreatic cancer is hypovascular. Biliary cysts don't enhance. Colon cancer typically has mucin in it, so it's actually hypovascular. Excellent. Last case. Cystic lesion is identified at MRI with multiple internal daughter cysts. Daughter cysts. Yes, keep it coming. Excellent. So this is echinococcus, and that's a great diagnosis. If you see multiple small cysts within a larger lesion, that's what it is. Thank you all for listening. I hope that some of these points were salient and helped you in your practice. And then here's my email. Hit me up. I love looking at interesting cases. If you see something, send it to me. Thanks again.